Thank you very much for tuning in to the Situation Room this morning. Spice FM, Nairobi 94.4, Malindi 97.7, Nyeri 90.9, 96.7 in Eldoret, Nakuru 96.0, 102.5 in Kisumu, Mombasa 87.9, and Nairobi once again 94.4. We're also live for the next 2 hours on KTN Home. I'd like to say very big welcome to our audience on KTN Home. We're also live streaming the show on www.spicefm.co.ke as well as Spice FM KE on YouTube, on Facebook, and on Twitter. For the next hour, let's talk about the NHIF, the National Hospital Insurance Fund. Now, NHIF is what we've discussed many times before in this show. I mean, NHIF is one of those critical organizations in the management of healthcare, talking about hospital insurance, the way that NHIF comes to help people, the contributors. Remember, it's a membership scheme. It's those who contribute to NHIF are the ones that are entitled to get the benefits of NHIF. So there was a push around the country for the last couple of years for everybody to at least enroll into NHIF by contributing a certain amount of money. And then you get the benefits, and they expanded the kind of benefits that you would get with NHIF around the country. And then the NHIF has been embroiled in one scandal, just jumping from one into another, from the board to the management of the fund itself, to how the NHIF works with other healthcare providers, the hospitals, the partners, all around, all right? Went into a search for a new CEO. It took about 2 years. Then, in April this year, a new CEO took over. And this is Dr. Peter Kamunyo. And Dr. Peter Kamunyo is going to be speaking to us this morning until about 8 a.m. Dr. Ari, thank you very much for joining us, and very good morning to you.
Very good morning to you, Latif, and thank you for having me here.
My team also welcomes you, and my co-host also welcome you to the show.
Oh, thank you very much. Ndu and I didn't get the other name.
C.T. Muga.
C.T. Muga, yes.
Good morning.
Good morning.
Good morning.
Dr. Ari, it's been, about 4 months now into this job?
Yes, it is.
We like saying that people who come onto the show come and occupy the hot seat here when we're interviewing them. I think where you are, that's sufficiently hot enough.
Indeed it is. But I'm using it to warm up in this cold weather.
All right. How has it been in the last 4 months since you took over the helm of NHIF? What have you seen with, you still had experience. You have managed health systems, you've managed insurance and the rest.
Yeah.
But now coming to the helm of this big institution of national importance, just tell us your experience so far.
Yeah. It has been very interesting. Actually, the first thing that hit me is the scale of NHIF. The scale is really big. And if you look at the legacy, starting from 1966, when NHIF was set up as a department in the Ministry of Health, and the evolution to date, because looking at almost 43% of Kenyans in the database of NHIF, here we're talking about almost 22 million lives, with about 9.5 million principal members. We are looking at a very, very large scale. We are looking at an institution that literally touches the lives of almost every other Kenyan. So that was the first thing that I found, and from outside, many people do not see this. I think the other thing is about the number of people that are actually helped every single day. It might come as a surprise to you to know that per month we handle over 1 million outpatient visits and close to 200,000 admissions per month. So when you look at that, it shows you the kind of impact that we have on the lives of Kenyans. So that was the first thing that hit me. The second thing that hit me is that I have a team of people who really are dedicated to what they do. Many people who've been here for quite a while, a couple of new people, but we're very committed team that is here, that we are working together to make sure that we drive this organization to the next level.
And what is that next level?
The next level is a journey that we have been on since 1966. And I would like to take you through that journey a little bit. And that is universal health coverage. Being that everyone has access to quality healthcare that they need without financial impoverishment. Just to give you a bit of a history, I mentioned that in 1966, that's when NHIF was formed as a department. And at that time, the contributions was only 20 shillings. Then, and that was for statutory contributors, formal sector employed people. Then in 1972, there was an amendment of the Act, and that allowed a voluntary membership. So basically the informal sector. Then fast track to about 1998, when now NHIF became a fully fledged parastatal. And then another big milestone, as contributions continued to increase and the rebates to the hospitals continued to increase. In the year 2015, that's when we expanded the benefits to super cover, including outpatient, including very many packages, and it became even more comprehensive in terms of our reimbursement to the hospitals. So in terms of our journey towards UHC, it has been progressive. And what I keep saying is that universal health coverage is not an event. It is a process. It is a journey. And we've been on it for the last 54 years. Now at the point where we are right now, I'm sure you know about many reforms that we have been going through. It's not the first time. There have been a series of them, and all of them have contributed to improving NHIF to a certain level. But more importantly, responding to the needs of the people. Because if you look at the mandate of NHIF, which is number one, to collect contributions from members, to reimburse declared hospitals, and also to protect the funds of contributors. Now, with all this, we are driving and inching closer to universal health coverage. And right now that the membership is open to all, but also looking at how we contribute also on the other side, because we always talk about membership, we always talk about the contributions, but we're not looking at the impact we also have it on the provider level. Because with all those visits, they are going to hospitals, and our hospitals range from our category A and B contracts, which are government and faith-based organizations, all the way to our private hospitals. And we contribute a significant amount of revenue also to the hospitals. So when you look at NHIF from that point of view, we are actually sitting at the needers of our being and being able to provide service of healthcare across all the key areas. And then to add on to that, being one of the big four agendas of our Excellency the President in terms of affordable care for all, we are at the point where we are on course to delivering that by the year 2022. So
Kamunyo,
that is where we are going the next level.
That's great, as you've painted that picture. Unfortunately, as we look at the NHIF over the years, the picture that people see is that has been riddled by corruption and scandal. So in as much as it's something that is helping people across board when you go in to get medical care and attention, when you look at the face of it, the face that you see of NHIF is one of scandal and corruption. So what steps are being taken to make sure that that image, and not just on face value, but down to the depths of the fund, has been removed?
Great question, Du. And I'll probably start from a correction a little bit in terms of the scandals. I think we've also not been telling our story correctly. And when you look at the scandals or what has been coming out in the media, etc., we need to also look at areas that we have been doing well. Now, going back to the reforms have been designed, and what we are looking at to ensure that we reduce any instances of corruption. We ensure that we become fully transparent and accountable. In fact, that's one of the key areas that I'm concentrating on, that we ensure that we are 100% transparent and accountable. And how are we doing this? In part of the reforms, a key part is on our ICT reforms, whereby we're ensuring that we are digitizing all our systems and processes, starting from provider empanelment, ensuring the process of contracting is actually online. You're able to track your progress. If you go to member identification, and that is where we have one of the biggest challenges. It is interesting that when we mention the corruption, and just to give you a bit of perspective, is that of all the contributions that NHIF collects, about 90% goes back to pay for reimbursements to the hospitals and claims. Now, only about 10% is used for administration, and this is to administer and pay emoluments for our 1,900 staff, our 156 service points across the country, et cetera, et cetera. And in terms of our journey towards ensuring that we are accountable and reducing all those instances of malpractice, within the last 3 years, we have reduced our operating costs by 50%, from about 22.1% of our collections to in the last fiscal year of 11%. As you can see, it is a journey that we are committed to, but I think what will guarantee the success of it is transparency and accountability, and we're ensuring that all our systems are absolutely transparent. Even in terms of, as I go back to the digitization, member identification, we know one of the biggest areas that even NHIF loses funds is impersonation and fraud, even at the facility levels. And understanding that 90% of what we pay out is actually back to the hospitals, this is an area that we're focusing on. So in terms of, as we are going towards UHC, ensuring that our members are identified biometrically so that this cannot happen. And then in addition to that, after they've accessed the services across our 8,189 providers, that the claims are also submitted electronically through electronic claims.
So do you have
this is a journey that
do you have a handle on all of this? Because when we look at anything touching on scandal with health in this country, we're often told that there are cartels involved and some amorphous individuals or bodies involved. So you are aware of each and every hole where corruption could have found its way into the fund, and then now being able to plug those holes with identification on where these particular individuals may have been, and very aware then of how to plug it. Hello? Are you there?
Sorry, I didn't get the end of the question.
I'm saying, so now you're very aware of who is involved and where it has been in the past so that you can mitigate for the future.
I think if we're aware about where it all is, we would be able to, nip it. But as you know, things, matters, corruption, they're not done out in the open. So how do we ensure that we minimize that risk? Because one of the key things that I'm also doing is looking at where are the risks that we have and how can we eliminate it. And we know, even as they say in a lot of literature, people steal or there's corruption because of maybe two reasons. Either it is too easy to do it, or there's need. So how do we ensure that it is not easy for this to happen? And one of the things is to have transparent and accountable systems and processes so that you're able to see. And also in terms of being able to project, because when this corruption means there's an abnormal occurrence, because for us as NHIF, and that's why we're ensuring that this process of member identification, member accessing the hospital making a claim, that is all digitized, so that you're not able to falsify that data, because we identify each and every member that we have.
Dr. Kamunyo,
it is work in progress.
That would require that you invest heavily on some IT systems, and that would require that all the hospitals that have partnered with you ensure that their IT systems are up at all times. Now, if some of these hospitals are the ones that have been unscrupulous and are the ones that have been lodging these false claims, how do you beat that? How do you ensure that they have their system working at all times and that people do not start going into the hospital and they are frustrated because they're told systems are down, forcing NHIF to reverse some of these plans that they have?
Yeah, that's a good question. And like you see, our vision is to be a world-class social health insurer. So I always start by asking even my team, how does world-class look like? Now, let's go back to your question, because if we're going to be a world-class social health insurer, is whom are we interacting with? We currently have 8,189 providers across the country. And our engagement is contractual with each and every one of these facilities. So there are conditions to be able to operate. Let's also not forget that these hospitals are also in business. They're making a return. So we have agreed that they provide a certain set of services and we compensate them X amount. So in terms of the minimum conditions that we require for them to be able to interact with NHIF, they've already been spelled out. And by the time they sign on the dotted line, there's an agreement that they're going to comply. And this is the only way we'll be able to handle. Remember what I said when we started about the scale. 200,000 admissions per month or 1 million outpatient visits. It's not possible to handle that without a digital platform. So that is our focus. And indeed, we are investing a lot in that area. We've had our legacy system, which has carried us to this point. And at this particular point in time, we are undergoing reforms to have a new and improved system to be able to handle this. So it is necessary for the providers that we interact with to have these tools. And we know Kenya is leading in terms of digital connectivity, etc. And to be able to support that, also the Ministry of Health is looking at it. To ensure also all the public health facilities, we have our electronic medical records, and this is work in progress. So this is the transformation that I was mentioning that we are at the point of getting to the end of.
Dr. When fully implemented, what will universal healthcare look like?
Great. I actually have a very simple answer to that. And I would like you to look at the way NHIF is now, because I believe NHIF is the foundation and is the tool that that will deliver universal health coverage. Right now, we have 3 groups of members. Number one is the statutory or formal sector. And then number 2 is the voluntary contributors. Now, the voluntary contributors, because for the statutory contributors, we have almost about slightly over 80% retention. Now, for the voluntary contributors, that's where it keeps seesawing. So there are people who pay when they have need, and then others just don't pay, they forget. And then we have a third group that cannot afford at all. And these are the people we call the indigents. Now, for me, how I see universal health coverage looking like is that the group that is statutory contributors or the formal sector to continue doing that because they have access, and with the expanded coverage, it can cover. Then, number 2, the voluntary contributors to be encouraged, or maybe even to some extent be obligated to pay for NHIF. Then number 3, the indigents that we find that they are sponsored to do this. And if you look at even NHIF and what the government has been doing to support the indigents, I'm sure you've heard about the health insurance subsidy program for orphaned and vulnerable children, for the elderly. We have Edu Afia, we have Linda Mama, which since inception has assisted over 2.6 million women access maternal child health services who had no insurance. So by having the group that cannot afford to pay at all, or the indigents, sponsored, then we'll be able to achieve universal health coverage. So that is how I see UHC. And using a platform like NHIF, which is transparent and reimburses both from primary care services to some tertiary services would be ideal. Then after that, for the folk who feel that they need extra added benefits and they can afford, then they can have the other private insurance in addition to the services and coverage benefits that we offer as NHIF.
Talking of these benefits, how exactly has NHIF structured its functions to ensure that every Kenyan who is either a member or a possible or a potential member actually knows and understands the benefits and all these wonderful things that we are saying here?
Yeah. I will also confess a little bit that we've not been telling our story well, but we have been telling it, and we are continuing to. We have tried to reach as many people, and I think even traditionally you've seen in trying to get to mass media, the road shows that we've done, etc. But we know that with the scale of what we're doing, getting onto the digital platforms is one of the best. And over the last couple of months, we've also enhanced our personal digital platforms. So you can actually register onto NHIF from the comfort of your phone, both the smartphones and also the analog phones. You can select the provider of choice for capitation through that. Through the mobile app, we actually have a mobile app called My NHIF, and I hope that if you don't have it already, by the end of this show, you'll have downloaded it to your phones, where you'll be able to see the benefits, you'll be able to see all that. Then, in addition to that, in the last, actually 2 months, we have enhanced our state-of-the-art call center so that we can be able to interact with not only our members, but also all our other stakeholders in real time. So, and within the last 2 months, we've actually increased the number of calls that we handle by over 7 times within the last 2 months. So these are ways that we are ensuring that we are tuned to be able to respond to the needs of our members and also stakeholders.
We are speaking with Dr. Peter Kamunyo. He is the CEO of NHIF, trying to understand NHIF, the reforms that he has in place. He's just been in office for just about 4 months since his appointment. And then we want to look deeper into the corporate governance structure of NHIF, how to get rid of the bad image that NHIF has had over the last couple of years. And he's saying, we haven't been telling our story as well as we should have. So we want to understand, so how else are you going to tell the story that should have been told? Good morning, and how are you doing? Welcome to September. It's the first day of the new month, and this is Kenya's biggest conversation. In the room this morning, as always, is Eric Latif, Nduoko, CT Muga, and joining us on the line is the new CEO of the National Hospital Insurance Fund, NHIF, Dr. Peter Kamunyo. And before we went into the break, you were explaining and trying to paint the picture for us of how universal health coverage will look like and the successful implementation of this universal health coverage. CT, you had a follow-up question to that.
What I wanted to ask was, a lot of the innovations that are being made by NHIF, as is being reported by the CEO, have to do with internet connectivity, technological advances, excellent. But there is a very huge population in this country who do not have that connectivity, neither are they able to have it. What has NHF done to reach these people? I'm actually going back to what I asked and I'm expanding the question.
Great. And so we have, and actually that's where we started from. And one of the things that we have done is to expand our branch network. We have 70 fully fledged branches across all the counties in Kenya. We have another about 52 in all Huduma centers across the country. And then the rest is, to make 156, is our satellite offices. So in addition to all the other channels that we have to be able to reach our members or stakeholders, we have expanded our footprint on the ground. And these are also staffed by trained personnel who understand the services, and some of them in certain communities are able to relate and communicate to those communities. Now, in addition to that, we also partner with the counties, and in fact, because we're still in that topic of universal health coverage, up to now, about 20 counties have actually identified a few or a couple of indigents in their regions and paid for them. So when we're going through this exercise, we involve the county infrastructure to be able to get to the grassroots, as well as in conjunction with our branches and our satellite offices and presence in all Huduma centers across the country. So that is one way to be able to get to those who can't.
Now, let's look back at the beginning of this year. And NHIF started the year on really a bad note with very many contributors, with the proposal to raise the rates and also to come up with new restrictions. For example, saying that new members were to pay 6,000 shillings and then wait for 3 months before becoming eligible for the cover. Raised a serious outcry with the public. It had to take the president's intervention to say, halt this. Where are you on this? Do you think that this is a route that you want to try again with us, or are you reworking a way in which you can introduce this to us in a more palatable dose?
Okay. Yeah, I think the first thing that we need to do is to understand how the system works. This is an insurance model, whereby what the contribution that you pay, then you have a promise of a certain set of benefits. And those benefits are a lot more than what you have contributed. But how then is it designed to work? It's designed to work because with everyone contributing, not everyone will get sick and not everyone will use those services. So with that is now the pooling of the finances, and then we are able to handle the risk of the people who would require healthcare. Now, the challenge that we've been having, and I alluded to it earlier on, and it is a challenge not only for NHIF, but for all third-party payers across the globe, is that unless it is obligated so that you have a critical mass of contributors, when it is voluntary, what many folk do is that you wait until you have a need to pay. Mm-hmm. So especially after we expanded our offerings, so you can get a hip replacement now, you can go for major surgery, dialysis is covered, etc., etc. So a lot of people were waiting when they're diagnosed with a certain condition and they need to have treatment. That's when they start paying so they can access. If you look at this critically, what does it mean? It's almost like buying money. So you pay your 6,000 shillings and get your 130,000 shilling benefit. So how can we mitigate for that? Mitigating for that is to ensure that first we have critical mass, that as many people enroll as possible, but also, at the other hand, is to avoid this adverse selection of folks who, when they have the need, that's when they're joining. And if you look at some of our benefits, because even for specialized surgery, it can go up to $500,000. So if somebody pays 6,000 shillings just to come in and use $500,000, even if they continued being our member, how many years would they need to be our member even to be able to recover that?
Could all of this be because could all of this be because people just don't know exactly what is on the table that could be of benefit by NHIF? And then couldn't you go a little bit further in then making this information pop and plain to the average Kenyan in terms of what is available should they contribute regularly?
Yes, actually, you're spot on on that, and that is one of the key interventions that we are having in terms of being able to communicate. But you know, also it also involves a little bit of behavior change as well, and that is one of the key areas that we are actually going to focus on, because the benefits literally far outweigh. And I would like just to give you a little bit more of perspective, because earlier I mentioned that like the statutory contributors, their retention is over 80%. For the voluntary contributors, as at end of the last fiscal year, is at a paltry 23%. And of these 23% who are present now, the chances are probably they were not the ones who were there last year or the year before. So this contributes to a lot of that adverse selection. So what we've been saying, and that is where, if you are to really say what is the one big problem that we have, I would say it is that the voluntary contributors are not sustaining their membership. And if we can get a way to do that through what you're suggesting in terms of communicating about the benefits, this is what you'll gain. But also, on the other hand, making it even a bit more easier, because right now, I think what we have is you have to make the decision that let me pay my 500 bob now. If we can have a way that it can be obligated, it will become easier for that to be, because even the other systems ride on the benefits that NHIF offers. So I do indeed agree with you.
You said you had a membership of, is it 9.5 million?
Yes, that is the total membership, but the active members are about 5.1 million.
Okay, now
so
what,
Daktari,
how many members can you possibly have, given the working population of this country, or those who are able to work? If you were to get everyone who is able to join NHIF, what would that number be?
Let me answer that question in a different way. To get to universal health coverage, we need to have at least 80% of the population covered. So, number one would be all the members who have been members to continue being members. So there we are at 22 million, based on the 9.5 million principals and their spouses and children, making 22 million. So another 20 million, and we'll get there to absolute universal health coverage.
I think you know where I'm going with my question, don't you?
Yes.
Yes, because there are all these people who are not enrolled as members. What are you doing to ensure that they are enrolled so that this discussion becomes a different discussion?
Yes, and that is what we have been doing in terms of increasing enrollment of members. If you look back, even our engagements with the counties is to increase the membership.
How's that working?
But I would like us to look at it, peel it a little bit more.
Yes.
And in terms of the number of members and new members we get every year, it keeps increasing. But at the same time, the members who joined last year, after they've accessed their service, they drop off. The members who join again, they drop off. So the key is to ensure that sustainability. So every time we go on a recruitment drive, you find is the new people who have an acute need who join. So in terms of educating about why it is important to continuously be a member or obligate that would be the way to sustain it. And this is a challenge that is there also in many other countries whereby you're getting voluntary contributions for an insurance scheme.
Have you noticed how effective and how persistent and how irritating these gambling organizations are? I think yes. Now, they never let you breathe. Now, do you then have any doubt as to why they were so successful to the point where they ensnared very many young Kenyans and continue to do so? Yeah. Now, when you see a tactic that works, what you're offering doesn't actually have any negative effects. It's actually a win-win right throughout. But the win-win is being hampered by the manner in which you're going about the business of ensuring you get the best out of it. I am speaking, and I'm fully aware that you're just recently into the job. But surely, the health of Kenyans should take a very, should we say, a pivotal position in the functioning and the operations of NHIF. Wouldn't you say?
I totally agree with you. And it's a good example you've used, especially that one about the betting, etc. But also when you look at the human behavior, people paying for something that might or might not happen, basically I'm talking about the concept of insurance, very few people, embrace that, So it is how we also continuously convince. And I totally agree with you that is a constant communication, is literally being in your face in terms of this is what will happen, this is what will happen. But maybe also having consequences with it to promote, because, like obligating, like if you're going to get certain licenses. And let me give you a good example, like the borders, for example. They are all over the road, and you know that they are exposed to the dangers of the road traffic accidents, etc. And if they don't have NHIF, who pays for that? But if they can afford to also have that border on the road, can afford 500 shillings a month to cover not only them, including their family.
Can I jump in there as you go on? Because the thing is, it's not just about having the 500 shillings, Dr. but it's also about having an understanding of what that 500 shillings translates to. So if I have the 500 shillings, right, and I'm looking at a kilo of flour and I'm looking at a kilo of something else, and I can see the benefit that it has in my life today, as opposed to 500 shillings hanging somewhere in the clouds that maybe I can use in the future if I get hurt without any kind of grounded explanation, then it makes it a bit difficult. You'd be surprised, and maybe this could be of help to you, but you'd be surprised that how many people just do not know what that money that they would contribute voluntarily or otherwise every month. So maybe I could ask you a question then. What are Kenyans assured of with their voluntary contribution every month in the event that they get sick?
And before you come to answer that, Dr. I have a caller here from Kahawa Sukari, Nairobi, and this is Muigai. I think he wants also to contribute to the conversation. Muigai, good morning. Hello? All right, I think he's taken a bit of a break. So once he gets back, we'll get into that question. So just respond to that. I mean, what is it that we are assured of getting once you pay this 500 bob a month? Dr. Kamunyo. Dr. we are on you. We're saying, so what is it that you would get once you get this 500 shillings a month? What is it that you're assured of getting with NHIF? We're having a technical issue here. I think something happening with the lines and all. Our signal getting to Dr. Kamunyo and him getting back to us. The conversation continues. We are speaking with Dr. Peter Kamunyo. He is the CEO of the National Hospital Insurance Fund. He is joining us on the line. He's explaining, the workings of NHIF, the challenges that NHIF has had with the entire system. And I don't know if you can now get us, Dr. Kamunyo. Are you on the line?
Not yet.
Not yet. Yep. So you were saying, among the things that he also mentioned was a behavioral change campaign with the people. If you look at what you said, the betting organizations, what they were actually pushing is that behavior change. So they're onto your face all the time,
And the benefits.
and they're showing you the benefit on a regular basis. And also, as when he comes back, I'm going to also add to the question of looking at 500 shillings a month, or just breaking it down into a daily. Very many of these
You've gone to the
circles,
heart of it, Eric.
very many of these circles tell their members just contribute 10 bob a day, and they'll tell you they contributed 10 bob a day or 100 bob a day or
And this is
something
what
like
they
that.
got.
And this is what they got.
Yes.
They went
And this
to
500, if it's 5 days a weekend, you contribute 25 shillings.
yeah.
500 is daunting. 25 shillings is not.
Makes sense.
not.
Absolutely. It makes sense because if you break it down with the things that you would normally be doing on a daily basis, truly, that's what people are doing. You're spending 100 shillings on food, where you break it down where you're getting 10 shillings, 20 shillings on flour. We're not talking about sounding as rudimentary as we can. It's actually what is happening. So you can imagine if your healthcare also is broken down into a piece that you would also understand.
And you can
25
afford.
shillings, and I can afford it because I'm also spending a similar or even lesser amount on food.
And
Right?
that 25 shillings you can look for. It's something that's achievable.
You can say, so in the event that my children get sick or I get sick, right? I have put away 25 shillings every day and I know that they will be taken care of. I don't have to go and ask people for money.
Yes.
So it makes sense that way, as opposed at the end of the month, 500 shillings, somebody's looking at you and saying it's not going to happen. Sorry.
25 shillings, believe me, makes a lot of sense.
Makes sense for me.
Yes. Because you're talking about 125 shillings, 5 days. It makes a lot of sense. Even when you think of just the workings of that amount, it's something. Again, it's thinking through what it is you need to communicate so that it resonates with the people who are likely to actually pay or contribute towards it.
Exactly. And that's the thing. I don't know that it's people running away from of responsibility when it comes to healthcare. I think it's an absolute disassociation with, this thing. There's a fund that we all contribute to or that we are supposed to contribute to, but how does it actually help me as an individual? And I feel that if we had that comprehension, you wouldn't need to look for people to join.
Eric got it spot
They
on.
would come straight to you.
What SACCOs do, and even what some banks do, they break it down. These payments, they're broken down on a daily basis,
Into
and believe
literally
me, it becomes
bite-sized
very, very affordable.
pieces.
Yes.
Yeah.
The basic understanding of not just salesmanship but marketing always hinges on looking at markets that you are with a possibility of capturing and which haven't been captured. Now, your growth is dependent on how you actually capture this. Any individual who is an adult, and every year we have people entering adulthood in this country, and they're in large numbers. You target them from the time even when they're in university and onwards, even secondary school and onwards, thinking ahead. So that it's part and parcel of their planning when they think of their lives and what they plan to do when they enter the job market. So as part of what they do, they look into their health. You will never lack for contributors.
No.
And you'll have a mechanism that the contributors can actually resonate with and which they can participate in.
I think the insurance conversation and the savings conversation is a conversation that even goes beyond players such as NHIF.
It does.
It goes to the regulators.
It does.
And the regulators have a duty to create that education and awareness. So, for instance, if you talk about insurance, go to any person and ask them about insurance. Those that pay for motor vehicle insurance pay for motor vehicle insurance because it's mandatory.
Yes.
And that's it. So I'm required to have insurance stick on my car, and that's what I have.
It's a compliance
It's
issue.
just a compliance issue, not because you can see the need for this, not because it really makes sense or you see that you can derive the benefits from it. And also then looking at the various insurance packages. How many people know the difference between comprehensive and third-party insurance? Getting to a point where the other day I was seeing advertisements by the Insurance Regulatory Authority talking about comprehensive cover and that the driver is not covered in the comprehensive. And there you are thinking, But I thought that's why I was thinking comprehensive.
Yes.
So that all of us in that vehicle are covered. So you start wondering, okay, this is a
So
kind
how do I
of.
cover myself?
So how do I cover
And
myself?
the man who
then?
drives this car.
It's
most of
my
the time,
car. I have
yes.
paid insurance for it. So this is where the IRA comes in, because they have a duty to continuously explain to people, to teach people,
Educate.
and even bringing it to the school level and working with KICD to inject part of that in the curriculum. So as you grow up, as you're going through school, as you're going through education, you already have a better understanding of what insurance is, and not just looking at it from that finance point of view of insurance and all. And the people who hate math dropped
Done with that.
Yeah, they dropped business education or finance or commerce, and they moved on. Yet you need it at a point in future. Also, maybe the CBK as well, and the banking association, creating awareness about savings culture. It's the same kind of thing. So if we're talking about having more people joining a scheme such as this one, and you're talking about universal health coverage, understanding what universal health coverage is and what the benefits would be, that would need to have started earlier.
Yes, it does. And also partnering with other institutions that already have groupings of people within them, whether it's a chama, whatever you want to call it, whether it's the Border Association, whether it's the Fertilizer Group Association, the DIP, the Cattle Dip Association. Yes, because all these organizations exist within our community and they have memberships. So when you address them and the people whose voices they listen to also address them, then you actually find resonance with your message.
Your message,
Yes.
absolutely.
But it's on an ICT platform. It's on TV. Okay. Let's see how far that goes.
Yeah. One thing for sure, though, is that from various interactions with NHIF, even in the media, you'll see that they have those barazas. So they'll attend a meeting somewhere in the village, where the people who are meeting, especially using now the political structures, the governors, the counties, the county meetings. And that's why he was talking about the recruitment drive, using those structures. Now, if you can extend that beyond the political side, also going into the other community groupings.
You know, the Barasa is an excellent idea. Every day in hospitals, you have what you call a health talk. I have never heard a health talk including NHIF issues. I've never. And yet, this is something that happens every single day, and people listen.
Perfect opportunity to use something like that.
Yes, it's whether you've taken someone to the hospital or
Yeah.
you've taken yourself, but you get to hear it. And there's no better place to sell it. Meaning, go out of your way to sell it. I am bringing up this issue because I feel NHIF has not explored every avenue open to it to sell its wonderful services. Because the services that NHIF offers are truly wonderful. They truly are wonderful.
Yeah. So unfortunately, we developed a technical issue with our lines, and therefore our conversation with the NHIF CEO was cut short. Unfortunately, we'll continue this conversation some other day when we'll invite him, and so we can delve more into the conversation with NHIF. Dr. Peter Kamunyo is the CEO of the National Hospital Insurance Fund. He joined us this morning, explaining to us how NHIF is working, the kind of reforms that he's putting in place, he and his management team, with support of the board, putting in place so that you can see a better NHIF that's able to deliver this crucial national